and my alarm quick set is done. I'm going to back out of here now, back to my main screen. And down here at the very bottom, you're going to see these monitoring pieces down here. These dark blue pieces that you see down here, those are the monitoring in real time for the patient. So right now we have a tidal volume at 340, which matches this. Why? Because the patient's not taking any effort. The machine's doing all the work on its own. You have your minute volume. We have 340 cc's of air set at 10 breaths per minute. Multiply that and you get 3.4 liters per minute of air to this patient, or of cycled air to this patient. The minute volumes are a physiological need. These are very important numbers to keep. So I always keep tidal volume and minute volume. If your minute volume or your tidal volume down here is different than what you have set up here, that's a patient breath, or there's an issue with your circuit. But for the most part, if this stays at 340 and we have it set at 340, we know that the ventilator is doing all the work. Over here, when you hit this and you want to change one, you simply touch it. It's going to bring up a screen of all of these ones that you can change. Some of the things that I tell everybody to always monitor is going to be your peak airway pressures. So we're going to touch this one, it turns yellow. We're going to touch peak airway pressure. It automatically turns this over to peak airway pressure. Over here I have extended power and battery time. I don't want to display that because I'm going to be on most of the time on my plug-in power. So as I go over there, then I want to change something else to this over here. One of the other things that I monitor is PEEP to see if there's any changes in the pressures within the circuit. So I change my PEEP, so I have tidal volume, minute volume, PEEP, airway pressure, and PEEP. Now you can change these based upon what you feel is necessary for the patient. But remember, these are real time that the patient is experiencing with every single breath throughout the circuit. So any pressure changes or anything that goes on you're going to see immediately down here. Once I have this done, I've got my alarm settings done. Now it's time to connect it to the patient. So when I decide to connect to the patient, zoom out here. When I decide to connect to the patient, I don't want to do anything other than get this over the patient. If I were to take this off of the mechanical lung at this point and not occlude this end, I'm going to get a rush of air, about 3,000 or 4,000 cc's of air pushed through this as the machine tries to find where the pressure resistance is and compliance for the patient. And then they're going to start getting alarms. We don't want to do that. So what I'm going to do is I'm going to pull this off and I'm going to occlude the end. The first thing I'm going to get is a high pressure alarm. That's normal. I'm occluding the end. There's no way for that air to escape, so I'm going to get a high pressure alarm. Every time it attempts to deliver a breath, I'm going to get a high pressure alarm. That's going to blink red, and I'm going to get a red down here that says high pressure. The reason I'm doing that is because it's easier to get the patient connected. So now what I'm going to do is I'm going to go over to here. I'm going to put this patient on the ventilator, and it's going to start delivering the breaths through the ventilator. And as you can see here, the patient's lungs are going up and down with every individual breath. As long as there's no compliance issues or no interaction issues, you're not going to see any alarms. However, we need to troubleshoot some alarms should they do occur. So one of the things with ventilators is when we switch from a patient that's on a ventilator on the floor or in a unit or from in the emergency room and we connect them to our ventilator, not all patient ventilator changes are smooth. And so the patient sensitivity to this ventilator may be significantly different to the sensitivity that they've been dialed in on the particular ventilator that they're on. So they're much more comfortable with that. So a change with this patient can be somewhat irritating for the patient, and they may not be as compliant as they were with the ventilator that they were on. It's not always necessarily a problem with your settings. Although you need to check those, we need to make sure that the patient is comfortable with adequate sedation, pain control, and those types of things to make sure that this transition to the sensitivities is good. As always, you're going to monitor your end-tidal capnography, your SpO2. You're going to monitor all the things and parameters to make sure that the patient is hemodynamically stable, as well as all things remain within the accepted parameters for a patient unchanged. So if you have a patient that goes from 98% on their ventilator over there and they're 92%, the first thing I'm going to do is put it back on their ventilator and allow that to, and then I'm going to recheck my settings. I'm going to check my oxygen settings, make sure I do have a full tank, make sure something's not wrong there, make sure that my oxygen FiO2 is set up like it's supposed to be, and then I'm getting adequate readings, those kinds of things that you're going to want to check right away. But from a ventilator-patient interaction standpoint, we're going to go through some monitor alarms here. So with these alarms, what we're going to do is review each one of these and kind of talk a few seconds about each individual one as we go through. So as I zoom in here, you'll start to see these parameters come up on this screen. The first one that's over here on the top of the screen here is the high pressure limit. Now, anytime I see changes in a high pressure limit on a patient ventilator interaction, I think a problem with the patient. So the reason I say that is because if the patient's biting on the tube, that will change the diameter of the tube. That will increase restriction of the airflow going through the tubes. The machine is very sensitive. It's going to notice that. As we go through, if there is a patient that develops a pneumo or a patient that has a sudden increase in pressure, if the patient's coughing, anything like that is going to give you a high pressure alarm. If there's any resistance to this circuit, you're going to get a high pressure alarm. Are there things with the circuit itself that can cause a high pressure alarm and other things? Yes, but they're far less frequent. Now, if you step it on the circuit, on the ground, you got the tube pinched off completely for the circuit, you're going to get a high pressure alarm. Again, I always think pressure increase has to do with the patient, because most of the problems that we have are going to be a high in pressure increase with that. If the patient's attempting to overbreathe the vent and the vent's trying to push air in as they're trying to get air out, the machine is not going to allow them to do that very comfortably. So again, in most of those situations in a high pressure alarm, the treatment modality that we're going to use is, number one, make sure there's nothing wrong with the patient, check ventilatory status, check lung sounds, all those different types of things. And then we're going to look at increasing sedation or adding sedation to the patient. Remember, the patient that's sedated and nice and calm up on the ICUs because we're not moving them around up there. When we're transitioning to our cot, we're transitioning to the ambulance. We're vibrating down the road, potentially with lights and sirens. Even though they can't express their irritation internally, they may still hear it or feel it and subconsciously recognize that change and then display it as things such as biting on the tube or moving their head or trying to breathe hard because they're stimulated. So in those situations, again, do consider increases in sedation and in pain control and potential paralyzation once you've achieved adequate sedation. Low pressure alarm, I think a problem or a disconnect with the circuit. If you have a partial disconnect, or if there's on the circuit itself, there's these little pieces here that you can actually open up and close. And if you open one up, you're going to get a low pressure alarm. So a low pressure alarm is designed that if there is a loss of circuit pressure. If you have a patient that has a cuff that deflates, you're going to have a change in your pressure settings. If you have a patient that is taking a breath in at the same time as the machine, you may get a subsequent low pressure alarm that is weak. It won't last long, but if you have an air leak or a circuit disconnect, it's not going to go away. So when I say high pressure, I think patient. When I see low pressure, I typically think circuit. So those are the first things I want to check. Over here on this side over here is your increased minute volume. Increased minute volume may be increased patient efforts of breathing. And so if the patient is set on a monitor or a ventilator breathing of 12 breaths per minute, but they're breathing 16 times a minute, within a minute or two, you're going to get a high minute volume alarm because they're going to supersede the amount of liters per minute that the machine has as a high end because they're overbreathing the vent. Again, remember, minute volume is physiological need, so be careful in adjusting that too much, but look at your alarms and see why it's happening. Again, most of the time you may need to increase or decrease sedation. If a patient was breathing 16 times a minute and you give them sedation, and then now all of a sudden you're getting a low minute volume alarm, well, that's because the parameters have been changed, and so the patient's not breathing anymore, so it's going to default back to the ventilator settings. And so the only efforts the patient's going to receive in a ventilatory method is going to be derived from the monitor or from the ventilator. So you may get a subsequent low minute volume alarm. Again, a disconnect can cause that. So when we're done making any changes to the vent, in order to ensure that the changes that we made aren't causing these alarms, do an alarm quick set. So if you're making a change to this ventilator, after it works, you get it going for a minute or two, do an alarm quick set to make sure that any further alarms aren't based upon the changes that you made, but again, it's a patient and ventilator interaction issue. Respiratory rate alarms, again, obviously that's pretty self-explanatory. Apnea threshold is set at 20, and that we really won't be changing that too much. And then you have your FiO2 and your low FiO2. If you change your FiO2 settings, make sure that you again go through and change your quick alarm quick set, because it's not going to be adjusted. If you go from a 20% FiO2 to a 40% FiO2, the high alarm limits are going to be exceeded immediately, because right now setting it at 21% FiO2 or room air, the high level FiO2 setting is going to be 32, and then the bottom is going to obviously be 0. But if I change it to 40, I've already superseded the high, so I'm immediately going to get a high O2 alarm. So make sure that you're going through and you're doing your alarm quick set. So I'm going to leave it on the alarm screen here, and on the alarm screen I'm just going to show you what happens when you get an alarm. So I'm going to hold on to the patient's lung here and increase intrathoracic pressure just a little bit. And as this goes through and the patient goes to get a breath, I should get an alarm that happens pretty quick here with the high pressure alarm. There we go. So as you see, when this high pressure alarm comes up, it turns dark red. It's going to go away because it's only going to be there when a machine attempts to deliver a breath, or there's an increase in pressure within the circuit. It turns dark red here. So if it stays red, in order before I change any alarm quick sets, I need to touch that, go above the alarm pressure parameters for it to clear. Once I have cleared it, I'm going to accept it that I've made the changes. So I'm going to hit alarm reset and accept. It's going to turn black, and it's going to tell me potentially at times that there's still a high pressure alarm. If it's black, the alarm is not there. The machine just hasn't cleared it yet. If it stays red, then we do have an alarm that is not going away, and we haven't adjusted enough to do that. So I have a low minute volume and I have an increased pressure. The low minute volume comes up because over several breaths I have had an occlusion against the circuit. And if there's an occlusion against the circuit, I'm decreasing the amount of air in with every breath. So that at this point it has gone below the minute volume threshold. The minute volume, the low volume threshold was set at 2.3, and we were actually at 1.8. Now in real time, you can see down here it's at 2.8, so the alarm will clear itself. Up here it says low minute volume. I need to simply silence and accept. Both of those within a couple of breaths will completely go away then. And that's how you look at clearing your alarms. To disconnect your patient from the ventilator, once they have their ventilator set up and the respiratory therapist or whoever's there states that they're ready for the exchange to occur, please do not shut our system off. We're going to do nothing more than disconnect it in reverse, just like we did. We're going to occlude it. We're going to get a high pressure alarm that's going to pop up the next time it attempts to give the patient a breath. That's okay. When it does that, we're just going to hit alarm silence. We're going to allow them to get their ventilator connected to make sure that we don't need to transition right back to ours. Now, if you do shut the ventilator off, is it a big deal? No, other than it takes some time to get it set up. If the patient's on their ventilator for 30 seconds or so, go ahead and shut the machine off. Remember, when we do turn it back on, once it gets through its internal checks, the same settings are going to be applied because it's based upon the last patient that was set before the machine was turned off. So you're not going to have any real issues with it, other than let them get their patient connected to their ventilator. Give it about 30 seconds and then go ahead and shut ours off. Once you hit alarm silence, you got a little bit of time before the alarm's going to go back off and make any noise and irritate anybody, obviously. So you see these the red lines up here. Make sure that we clear those when you're with the patient. And don't be afraid to ask questions. Don't be afraid to take this out and work with it and play with it. And as always, if you have any questions with the patient in front of you, you can always call me at any point in time. Thank you.